Everyone. Thank you. Welcome to today's webinar on navigating crises in the humanitarian development peace nexus. My name is Christopher Lindahl. I'm the Deputy Director for Learning, Knowledge Management, and Strategic Communications for Momentum Integrated Health Resilience, and I will be shepherding us through our agenda for today. We can go on to the next slide. Before we get started, just a couple of housekeeping notes. First of all, the webinar, I think as many of you heard, is being recorded, and the recording and the slides will put up onto the Momentum website so that you can access them afterwards, share it with any colleagues who may not have been able to join. And as we go along, if you want to go ahead and put questions into the chat, we can address them at the end. We'll hopefully have plenty of time for Q&A at the end. We've got 90 minutes today, and so there should be a good 20-25 minutes at the end for some Q&A. And then the last piece is that this webinar is being offered in English, French, and Spanish. Actually, in order to get your language, you should at the bottom of your Zoom menu see that little globe that says interpretation. You can click on that and select the language that you would like to hear today's webinar in. Maybe one of our interpreters could just come off quickly and give that instruction on the translation in French and Spanish, please.
Venez d'annoncer. Donc, ne pas oublier de choisir le symbole d'interprétation. Comme vous pouvez voir sur l'image, si vous faites clic, vous allez choisir français ou anglais.
Okay, great. So let's go ahead to the next slide.
Muy,
And I'd
muy
like...
bien, vamos a la próxima
Oh,
diapositiva.
okay, go ahead. Sorry. Yep, go ahead. We want to do the instructions in Spanish. Go ahead, please.
Muy buenos días. Para poder escuchar
Alors, bonjour, pour
la,
pouvoir entendre,
la traducción en español, por favor,
pour entendre la
seleccionan
traduction en
en el
français ou en
globo
espagnol, vous allez
inferior, en la parte que
choisir
dice
sur le petit
interpretación,
symbole, la partie
selecciona
inférieure où
en
c'est
el
écrit
canal en que quiere
interprétation, vous
escuchar.
allez choisir le canal de la langue de votre préférence.
Great, thank you. Okay, on to the next slide, please, just for our agenda for today. We'll start with some opening remarks in just a second, but our first presentation will be on navigating the Nexus, key characteristics, challenges, and implications for health resilience programming, to just kind of set the stage for some of the presentations that you'll hear later on. We'll then hear 3 case studies from MIHR programs in Sudan, Niger, and South Sudan that are all have experienced different types of shocks and stresses, and so you'll hear about how they're adapting and adapting programmatically and operationally to meet those challenges. And then, as I mentioned, we'll have plenty of time at the end for Q&A. So I'd like to kick us off on the next slide to introduce Nefra Faltis for some opening remarks. So Nefra Faltis is the Senior Child Health Advisor with the USAID Bureau for Global Health's Office of Maternal and Child Health and Nutrition, where her roles include supporting management and technical oversight of Momentum Integrated Health Resilience. She's also co-founded and co-chairs the Bureau for Global Health's Resilience Technical Working Group. She brings more than 18 years of experience in clinical service delivery, preclinical research, and global health programming, and policy experience in maternal child health and nutrition, community health, infectious disease, supply chain, family planning, reproductive health, gender, nutrition, malaria, and HIV/AIDS. And she's worked in more than 30 countries with her work spanning the Ebola response in Eastern Democratic Republic of Congo to strengthening routine immunization in northern Nigeria. Her work is largely focused on fragile and conflict-affected settings, particularly in West and Central Africa and the Middle East. Over to you, Nefra.
Thanks very much, Chris, and good morning, good afternoon, and good evening to all, wherever this finds you. Thank you so much for joining what promises to be a rich learning exchange. Momentum Integrated Health Resilience works to improve the access to and the availability of quality, respectful, and people-centered maternal, newborn, and child health, family planning, and reproductive health care, and to support resilience building in fragile settings from Mali and Burkina Faso to Yemen and the Democratic Republic of Congo. And in some ways, the project is designed specifically to help us demonstrate and learn how a health development project can operate effectively in settings facing recurrent and often concurrent shocks and stresses. And that includes understanding what adaptations are needed to ensure the continuity of essential health services when shocks and stresses hit, how to pivot operations to keep project staff safe and paid when the operating environment becomes less permissive, when and how to apply humanitarian principles like impartiality and neutrality, and where a development project like this appropriately fits within the complex dynamic ecosystem we call the Humanitarian Development Peace, or HDP Nexus. Now, navigating the HDP Nexus is an increasing priority for USAID, so much so that we're updating our 2012 resilience policy and embarking on the development of an HDP policy. Why does this matter for global health? Well, so many of our partner countries are becoming increasingly complex risk environments that are vulnerable to humanitarian crises. And that really threatens further progress towards shared goals like preventing child and maternal deaths and combating infectious diseases. So successfully navigating the HDP nexus, or in other words, strengthening HDP coherence, can help us protect and advance these gains, build the resilience of people, communities, and systems, and reduce the need for future humanitarian assistance. We are thrilled to have with us today expert colleagues from our Momentum Integrated Health Resilience country programs in Sudan, Niger, and South Sudan. All of these country contexts face protracted political, conflict, climate, and other crises, and yet all of these country programs have managed to adapt to and even thrive in the face of these crises. We'll hear about how key programming principles like context specificity, conflict sensitivity, and localization relate to HDP coherence and resilience building. We'll learn promising practices around how to balance short-term emergency response actions with longer-term planning and delivery of routine health services. And we'll see how shock responsive programming has shaped Momentum Integrated Health Resilience's approach to data visualization for reporting, adaptive management, and storytelling, but really so much more. And all of these examples will underscore that operating in the nexus is not a linear process of simply just moving from a humanitarian assistance modality to a development assistance modality. Instead, it really requires a constant stock taking, reassessment, and flexibility along a very fluid continuum. As Chris mentioned, we also hope to allow ample time for Q&A and to hear from all of you on the line about your own experiences and learning. But with that, please do not wait for the Q&A portion of the program to do so. We really encourage you to place comments and questions in the chat, perhaps even talk to each other in the chat along the way. And our moderators will strive to help us address as many of those comments and questions as possible. With that, Chris, back to you.
Great, thank you so much, Nefra. We can go on to the next slide for our first presentation coming from Andrea Patterson. Andrea is the Health Resilience Lead for Momentum Integrated Health Resilience and brings 15 years of experience in senior health leadership roles that combine strategy, planning, technical support, and advocacy in conflict and post-conflict countries in Africa, Asia, and the Middle East. Prior to joining Momentum, Andrea spent 6 years as the country director for Relief International, leading the expansion of complex health programs for Syrian populations in Lebanon, Syria, and Turkey. Andrea, over to you.
Thank you so much, Chris. Let me just turn my video on. Good morning, everyone. Good afternoon. Thank you so much for being here today and for joining our webinar. As Chris mentioned, I will be speaking to you today about navigating the nexus, key characteristics, challenges, and implications for health resilience programming. Next slide, please. The Humanitarian Development Peace Nexus, also known as the Triple Nexus, refers to the approach that address the interconnected challenges of providing humanitarian relief, long-term development, and fostering sustainable peace in fragile contexts. And as Nefra mentioned, these are the contexts where MIR is operating. And as she also mentioned, it's not a linear process. It doesn't move from humanitarian to development to peace. It's a simultaneous effort to address these challenges in fragile settings. While discussing fragility, it's important to understand that all countries experience it differently. And even within countries, different populations and regions can have varying levels of fragility. And while every country is different, there are some common themes: extreme poverty, weak governance, weak social cohesion, high levels of violence and insecurity, vulnerability to climate change, exacerbating existing vulnerabilities and creating new health challenges. Some of the key characteristics of navigating the Nexus include, and I'm only going to name a few here, focusing on the integrated approach, tailoring approaches to local dynamics, localization, engaging diverse actors, both health and non-health, including the private sector, particularly with job creation and economic development, adaptive programming, as Nefra mentioned, the importance of pivoting, being able to pivot and change to adapting circumstances, and focusing on long-term resilience and systemic change. However, implementation in the Nexus comes with several challenges. There's a lot of different actors. Often there are issues with siloed funding mechanisms, different mandates and operational cultures across the organizations, coordination challenges among stakeholders, whether it's under coordination, sometimes as we saw in West Africa on the Ebola response, there's over coordination, leaving less time for implementation. And there's a need for a deep understanding of the local context. It's not a one size fits all approach. There can be lack of flexible long-term funding and a lack of shared data and coordinated analysis, which can lead to fragmented approaches. In the next slide, we'll see the impact of fragility on health, and you will see how the Nexus approach becomes essential in addressing these complex challenges. The impact of fragility on health is multifaceted. I'm humbled to have several colleagues on the webinar today who live on the front lines and know these challenges better than anyone else. Before speaking to you about the impact of fragility and what's written on the slide here, I just wanted to mention a few statistics. And I know a lot of us are probably already aware, but I think it's important to mention that fragile states have some of the highest maternal mortality ratios in the world. Approximately 60% of preventable maternal deaths and 53% under 5 deaths take place in fragile settings. What do these numbers mean? Well, in DRC, for example, 4 women die every hour during labor or due to pregnancy-related complications. 80% of the extreme poor live in fragile settings. In 2022, the 20 most fragile states had a combined population of 950 million people. The COVID pandemic has pushed 40 million people to extreme poverty and left 250 million on the brink of starvation. There are over 100 million forcibly displaced people worldwide and about 50 million IDPs. The impact of fragility on health is extensive. I won't read all the points on the slide here, and this is certainly not complete, but we'll mention a few. Health services are frequently disrupted. Health workers and facilities may be targeted. Managing chronic conditions such as diabetes, hypertension, cancer becomes particularly challenging in fragile environments. Supply chains are often disrupted. Epidemics can spread rapidly, overwhelming strained health systems. Refugees and IDPs faced increased health risks. There's several barriers to accessing services if they are available: cost, distance. Gender-based violence often increases in fragile settings, and the trust between communities and the state often breaks down, with critical implications for health-seeking behavior, service utilization, and health system and community resilience. Ultimately, the discussion on fragility is about human beings. It's about life and death. While operating in the Nexus, as we've discussed, it presents numerous challenges, but it also provides an opportunity to build stronger, more resilient health systems. Next slide. So why focus on resilience building? Moving away from a needs-based approach to resilience building is crucial because it addresses the root causes of vulnerability rather than just addressing the symptoms. At Mirror, we use USAID's definition of health resilience as the ability of people, households, communities, systems, and countries to mitigate, adapt to, and recover from shocks and stresses in a manner that reduces acute and chronic vulnerabilities and facilitates equitable health outcomes. Building resilience involves enhancing three main capacities: absorptive capacity, prevention and coping measures; adaptive capacity, making changes in response to longer-term challenges; and transformative capacity, enabling systemic change to address underlying vulnerabilities. And we'll see examples of this in the country presentations. Next slide. Building health resilience helps communities and health systems to better withstand and recover from shocks and stresses, and ensuring that health systems are not only reactive, but also proactive in preventing and mitigating the impact of future shocks and stresses. Our approach at MER is also informed by the socio-ecological model, recognizing that health outcomes are influenced by factors at multiple levels, from individual behaviors to broader societal policies. And at MER, we focus on several key strategies to operationalize our approach. First, and perhaps most important, we start with conflict sensitivity and identifying the risk scenarios likely to impact the health resilience of the target population, while also ensuring that our interventions do not exacerbate existing tensions or create new conflicts. Next, assessing resilience capacities at the various levels in the face of prioritized risk scenarios. Then we strengthen resilience capacities, as I mentioned above, and we'll see examples of this again in the country presentations. And continuous and participatory M&E, and which is a continuous learning throughout the evolving context. We emphasize also flexibility, adaptability, and strong partnership with local organizations and communities. Community ownership and engagement is really important for sustainability of the intervention. And also the importance of humility, to learn from each other, to learn from our failures, and to talk to new and different stakeholders. Thank you so much.
Great, thanks, Andrea, for setting the stage there. I'd like to now turn it over to our first case study. If we can go on to the next slide, will be presented by Mohammed Abdel-Gadir. He's a medical doctor with a master's degree in tropical medicine from Nagasaki University in Japan. He has over 15 years of experience in humanitarian and emergency settings, working in different capacities to lead health and nutrition programs for international NGO missions in several countries in the Middle East, Africa, and Asia. He's currently the chief of party for Momentum Integrated Health Resilience in Sudan. Mohammed, over to you.
Thank you, Chris. Good morning, good afternoon. My name is Mohammed Abdel-Gadir. I'm chief of party for the Momentum Integrated Health Resilience Project in Sudan. I'll present to you today the impacts of the Sudan civil war on the Ahmed Shah project intervention and how the Ahmed Shah program adapts and responds. Next slide, please. In April 2023, violent conflict erupted between the Sudanese armed forces and the Rapid Support Forces, RSF, with the state of the economy already precarious, exacerbated by social unrest, shortage of basic services and livelihood inputs, and different and freezing of the foreign assistance. The military conflict has reactivated prayer fault lines in different parts of the country and risk pushing the country into the state of collapse. 14 months of ongoing conflict have created a severe humanitarian situation and the world's largest displacement crisis. Its effect reached almost all neighboring countries, which also facing several internal challenges. Next slide, please. Impact of the ongoing armed conflict, human rights violation, killing, abduction, arbitrary arrest, conflict related sexual violence, torture, indiscriminative bombing, and also forced displacement. Over 16,553 fatalities, including thousands of children. 4 million women and girls at risk of the gender-based violence with limited access to the services. Massive displacement, the largest internally displaced population in the world, with over 11 million people, or in every 5 people in the country, there's one displaced. Since the conflict erupted in April 2023, Sudan, this based on the recent statistic. Imminent famine and acute malnutrition, more than 1/3 of the population is facing severe food insecurity, with 4.9 million on the brink of the famine. Collapse of the health system and increased environmental health risk. 80% of the health facilities are no longer functional, and 65% of the population lack access to the health services. And the increased disease outbreak, at least 2/3 of the states in the country or the region of the country are experiencing 3 or more outbreaks of the different diseases, simultaneously, including malaria, cholera, dengue, suspect pertussis, and also meningitis. The health staff are not paid for almost more than a year across the country, and disruption of the supply chain system. Also, given on top of that, the humanitarian access has been severely impacted by the insecurities, looting, and bureaucratic impediments. And at least 24 humanitarian workers have been killed. Next slide, please. The impact on day-to-day operation, interrupted service delivery, temporary suspension of health service at 10 IMHR supported health facility in Dalan and Habila district during the escalation of the conflict between the SAF, RSF, and SPLA North Al-Hilwin, that during January, February 2024. Interrupted supply chain system, restricted movement of supplies between South Kordofan, where IMHR has operation sites, and other states, and that greatly impacted the level of stock for almost all the basic supplies, including the medical supplies. And also the severe restricted staff to access the project site. This also has impacted the quality of the service we provided. Impact on the staff, almost all the staff has been displaced, and some of them they have been displaced more than 3 times, and also impacted their mental and physical health. Interrupted telecommunication service, which isolates sometimes the field office from the communicating with outside teams. Next slide, please. Programmed impact and response. Interrupted supply chain and operation system, inability to complete the procurement of the planned activities, like an inability to bring in supplies, material, or to buy a service from outside South Kordofan. For instance, inability to install solar system for health facilities and water yards, inability to transport a spare part for the water yards and in the field operation areas, and that affected the quality of the program. The adaptation, IMHR is in collaboration with the humanitarian actors, UN agencies, specifically NRC, the Norwegian Refugees Council. IMHR has managed to borrow some spare parts and to repair a total of 23 hand pumps water point in Kadugli. Inability to access site in Dalan and Habila, replace also the reduced quality of program activity due to Operation Kennedy. As I mentioned, IMHR adapted the adaptation that made to the program is reprogramming of the resources to another new location that is relatively safe or accessible in Eastern Sudan. That happened in January 2024. interrupted MSH services. MSH is not able to pay staff salaries for health staff for more than a year. So the adaptation made by MSH is providing direct humanitarian assistance to the improve the health service delivery, and that improve the service uptake and also the local communities to access the health services. Next slide, please. Trend and analysis. Here, this graph is showing us the trends analysis of the ANC visit 1 and visit 4, comparing the effect of the shocks, the conflicts and disease outbreak on the service uptake, and also how that can reflect on the program data. The orange line in top showing the reported ANC in all IMCR supported health facilities in Delhi, Habila, and Kadugli district. We can see sharp decline observed in mid-April 2023, that when the conflict started between RSF and SAF in Khartoum. Second, we see another decline that in June when the conflict started in South Kordofan. And when the cholera outbreak reported or increased in Delhi, we observe that the service uptake little increase, and that also can reflect the people they are seeking medical assistance at the health facility, including the pregnant woman, so that little improve the ANC visit. And that correlates also with the shocks and stresses. So also in October, by end of October or by mid of November, there is also conflict erupted escalated in the 3 districts, where you can see also sharp decline of the ANC and BNC visit. And that can show the impact of this shock and stresses on the people ability to access the health service. Next slide, please. So the responses phase out from Habila and Dalanj district by end of project year quarter 3, reprogramming of the available resources to support the MSH intervention into new localities in Eastern Sudan, where the access is still possible, and these 2 states are relatively safe and accessible, as I mentioned. Change of modality. So from facility-based to community-based service, supporting the community MNCH to help the community access to the health service at the community level. Adapted tools to collect data from the community to better reflect the service provided in the community because of the conflict. Supported distribution of the emergency health kits, including clean delivery kits provided by WHO to AMISHA support health facilities. In response to the collapse of the banking system, AMISHA used mobile money to cover the operation costs at AMISHA operation areas in Kadugli, Dani, and Habila, and also to pay staff salaries and also to pay the vendors and suppliers. Use of remote management to provide needed support to the AMISHA operation areas at the field level, weekly meeting with the AMISHA program meetings. Joint collaborative effort led by UN OSHA to transport humanitarian supplies to South Kordofan. WHO has donated 44 emergency health kits that plan to be distributed to AMISHA support health facility in Dalan and Habila and Kadugli. Next slide, please. Plan activities versus response adaptation. Plan to install solar panels to support child immunization service at 6 AMISHA supported health facilities. Actual provided fuel when we are not able to provide or to install the solar panels, so we provided fuel for generators. at 4 health facilities to support the child immunization. And that also help to improve the access to the immunization service. Plan to install solar panels in water yard in Kadugli district. The actual response IMSHA supported community-led solution to repair 23 hand pump water point in Kadugli district in South Kordofan. Plan also face-to-face capacity building activities, including the supportive supervision to IMSHA, to MSH provider at the health facilities and other plan training with support from IMSHA technical leads. Actual remote supportive supervision continued through the phone, WhatsApp calls, particularly for MSH provider in Dalan Habila. And also the IMSHA carried out 3 training outside the country in Kampala, in Uganda, including the social analysis and action, supported by SBC technical leads and CARE International Global Gender Cohort team. And the health facility emergency preparedness and response planning with support from GOAL International Health Resilience team. Also planned field visit to IMHR operation site in Delhi and Habila, the actual response, hiring local consultant to support data collection and also to support the monitoring of the IMHR program activities in Delhi and Habila. Next slide, please. The IMSHA has supported the establishment of community-managed maintenance and repair team, circuit rider team, in close collaboration with community leaders and WASH stakeholders. The community-managed maintenance and repair team comprised of 10 young men and women that have been selected from the catchment area of IMHR supported health facilities, and they have been trained and equipped by IMHR to repair, inspect, and monitor the water yard in the catchment area. The community maintenance and repair team has repaired a total of 23 hand pumps in Kadugli district, in the catchment area of IMSHA support facility, and through that, IMSHA has improved the water availability at the supported health facilities, as well as to the local communities, including the IDBs. Next slide, please. Recommendation, recruiting staff with roots in projects area. Recruiting staff from the local communities in the project operational area helped IMSHA maintain operation following the outbreak of the conflict. Amidst all key staff in the field from Kadugli and Dalan, because staff remained at duty station and have a strong relation with local communities. Strengthening the capacity of the local institution to deliver and manage WASH and MSH service. Through working closely with community leaders, IMSHA formed and trained and equipped the 10 young men and women to help maintain the water system in Kadugli. Use the theory of change and strategic planning to help guide response to the to respond to change in the operating environment. IMSHA adapted its operational and programmatic strategy to reach people with IMSHA, MCH, and water service after the conflict began and continue throughout the conflict. Partner with local actors that are independent and politically neutral to improve access and enable adaptation and fast response. An example is South Kordofan Midwife Association, which is professional association in which all midwives in South Kordofan are members. More than 1,000 midwives are registered, representing all geographical and ethnical communities. Therefore, the Midwife Association has maintained access to all IMHA operation area amid the conflict. Next slide, please. Here, this picture is showing the Midwife Association, the senior management. IMHA partnered with the Midwife Association 8 months before the start of the conflict in Sudan. Through the midwife, IMHA provides supportive supervision and clinical mentoring to midwife in the catchment area of 15 health facilities. And the conflict disrupted the health system in the state, but did not stop the Midwife Association from continuing its activity because they have a presence in all districts, villages, and also the towns. And the only adaptation they made by the midwife association, they moved from using public transportation, from using like a private vehicles, they use public transportation to reduce the security risk. Also, IMCHR supported the association internal administrative, financial, and also to build their organization capacities. Thank you. Now I'm handing over to my colleague to present case study from Niger. Thank you.
Thank you so much, Mohammed. I think I saw one question come in for you in the chat, but we can address that at the end during the formal Q&A. So I'd like to turn it over to our next presenter to present our second case study on the coup in Niger. Sagana Maina Bukhar is the chief of party for MIHR in Niger. He's an epidemiologist with a master's degree of public health, specializing in epidemiology and population studies. Prior to joining Momentum, he was the director of USAID's Applying Science to Strengthen and Improve Systems project for Francophone Africa, and he has worked at all levels of the health system in Niger. Bukhar, over to you.
Thank you, Chris. Morning. Yeah, it's a really honor to share our experience here in Niger after the coup. Next slide. Here are some figures on the context of Niger. Niger is one of the very less developed country. We're almost behind of the UN index development. Also, we're experiencing a lot of vulnerabilities on food, on political, but also on the instability across Sahel with all these jihadists and neighboring countries. We have Libya, we have Chad, Nigeria, Burkina Faso, Mali, all these countries with really severe instability and insecurity issues, including Niger. The population growth rate, you see, is almost 4. The fertility rate in Niger is one of the highest in the world. Life expectancy is also very low. Child marriage is very high. MHR is working in 2 regions out of the 8 regions of the country, Dosso and Tawa. In each of these regions, we work in 3 districts. Next slide. So, to this really fragile, I would say, setting, there was a coup and its consequences. The first consequences was the really sanctions by the ECOWAS, the regional economic West African states, and the West African Monetary and Economic Union. As you know, all West Africans, the 16 countries are very tight economically, financially, and also on population movement. They are very tight. And once this coup happened in Niger, they take very severe sanctions on all aspects of the life. They close the borders. They really, I would say, suspend all commercial transactions, freezing Niger assets. Commercial bank were really suspended, and so also 2 of our main. Niger is a landlocked country, so we have access to the sea, to the ocean through Benin and Nigeria. This border also closed. One of our biggest, I would say, partner was France, and the relations between France and Niger also really become very deteriorated. Most flight from Europe come from France, so this also was stopped. No entry for French citizens, and even for other African, they have to really go through other countries to come to Niger. To this environment, also Niger was also hit by restriction 70 or 9. When there is a coup, there is a law from the US that really suspend some activities. For us, it was on family planning activities. Family planning activities mostly in government-owned facilities. As you know, most of the facilities here in Niger are government-owned. Really are public. I would say here in French, it's public facilities. Almost maybe 80 to 90%. Private facilities are mostly based in urban areas, and you know, Niger is a really mostly rural country. Next slide. So, what was the impact on the day-to-day operations? The restriction 7008, we had to pivot our family planning activities because before the coup, most of these activities were at the facility level. So we have really to adapt and to focus on community level, on private sector, and which has a unfortunately, a minimum footprint in Niger. Another consequence of this coup was also access to cash flow at banks. It's really affected our activity implementation and also our staff salary payments. There were also, as there are new authorities, new, I would say, managers were all replaced. So we have to manage with new administrative authorities at the district and the regional level. Unfortunately, this is lost in momentum and the support from previous governmental officials and the community elected leaders. We have been implementing the project. This is our third year, so really we have created a momentum, really very positive, I would say, assets and the support, and all this really was a little bit disrupted. Also at the MOH health managers, this was also a loss in investment on training, assets, on maturing common vision of MHR. You know, MHR is really a special project, special, well fitted to this setting, to this project setting. So those with which really were really having the same vision, the same, I would say, perspective were replaced. So, and there were a little bit, new managers, or maybe new managers were a little bit reluctant on this new strategy, just leaving the facilities and go to the community level. Next. Instead, in terms of indicators, yes, there was really a small but noticeable impact on family planning as a result, mostly on postpartum family planning. You know, postpartum family planning, it's at the facility level, it's not at the community level where you create demand. You really create and you increase attendance to health facilities. This really was one of our really negative impact on postpartum family planning, not on all indicators on family planning, mostly on postpartum family planning. Next slide. So how did we adapt and the pivot? On the operational level, we did a lot of adaptive management. We really, each time there is an issue, we adapt. Each time we adapt. Really, we use very highly this adaptive management. We shifted financial operations, such as a staff pay period, to ensure that salary payment were available in a reduced banking system. Mostly people are paid here around the 20th of each month. So the bank were very crowded because everyone would go at the same time. We requested and we could get the permission to our staff to be paid on the 15th before the crowd. Also, we adapted our capacity building on insecurity. We moved, for example, community locals to safe environment and train them and go back. We use local really trainers to go back and train also. We also notified banks at least 2 weeks in advance to get cash, because really it was an issue even at the bank level. So if we want certain level of money, you notify the bank at least 2 weeks before. We also used private money transfer companies, which was not common before the coup. Now we are using them, and fortunately for us, they are available at the district level. At the programmatic level, we pivot our family planning activities from public health facilities to community level. Community level, we recruited local NGOs. We also include now private facilities, which was not so usual with MHR. Here in Niger, we have the Memorandum Private Health Delivery Project too. So with the mission we discussed, and they agree that we also focus on private. And it even allow us to add a third region, the capital city, Niamey. So we're also working in Niamey in private facilities. We also had a lot of discussions and negotiations with AID to allow the community relay for family planning service delivery. We also strengthen some of our ongoing strategies. One of our strategies, first-time parents, it is really led by community workers, and we reinforce family planning activities within this strategy. Another strategy where we strengthen our family planning activities is care group. It's primarily on nutrition, but we also add family planning activities. So by doing so, we really increase the creation of family planning services at household, individual, and through the referral. First, to the referral system. Next slide. So what have we planned, and what did we do after the coup? For example, our plan was really to provide monitoring, supervision, and the capacity of family in all public in our province. And pivot was really to expand family with community relay, community workers, and the local NGOs, as I said. Also, we include, this is new after the coup, we included private facilities too. In Niamey, you see, this is a new region, and Dosso and the tower. It was also planned to in-person short-term technical assistance to support our programs. So what we did was really some international staff supported workshops, mostly online remotely. We regroup people in the region or the district where they have the internet, and we do the training. We also planned to maintain and finance and operational policy and procedures. What we did is revise some organizational financial and operational policies, such as a result of really access to cash flow. So what we did, use the transfer, notify bank, change the period of salary payments, and so on. Next slide. What do we recommend? This is really lesson learned. The project was designed with decentralized activities at the district and the regional level. We have really staff at the district level and the regional level. This really allow us to be very close to where operations or activities are taking place. So even with the coup, really, we could use our own staff to really to continue supporting those activities. Also, one of the lessons learned is localization. Localization means strengthening local partners like NGOs, like private sectors. We strengthen our NPI, new partnership initiative. It helps us a lot really to strengthen our activities, and the localization is really here we saw its added value. We also use different really methods of monitoring and reporting trend and impact. Continuously we adapt using a lot of WhatsApp groups for each key activity we create, depending on the topic, depending on the beneficiaries. We create WhatsApp group to discuss, to answer to questions, to share lessons, to etc., etc. We also intensify the number of staff meetings. For example, from here from Niamey, we have each Monday we have a meeting remote with all district, regional, and there's a national people. We have also another one. This is on activity implementation. We have another one on Friday on monitoring the work plan. How are we doing? Are we behind? How can we adapt? So these are really some of the lessons that we learn and that we recommend. I think this is the last slide. Thank you very much.
Great, thank you so much, Bukhar. We can go to the next slide. And I would like to now turn it over to our final case study coming from South Sudan, who will be presented by Dan Wendo, our Chief of Party in South Sudan. Dan is a physician with over 40 years of experience in designing, leading, guiding, managing, and evaluating integrated health programs in several countries in East Africa. Since May of 2021, he's been the Chief of Party for Momentum Integrated Health Resilience in South Sudan. Prior to joining MIHR, he served as Chief of Party for USAID projects in Kenya and Malawi and spent time as a Public Health Service Director for several Kenyan districts and urban areas. Dan, over to you, if your internet is cooperating.
Thank you very much, Chris. I hope you are hearing me, because I'm about to change computer now, talking as using business computer.
Thanks, Dan. It's a little quiet. If you're able to maybe get a little closer to the mic.
Okay. Thank you. I will be doing a presentation on our violence to the health workers in South Sudan. Next slide. Next slide. Up. Good. Yeah. The South Sudan is the youngest country in Africa, so we speak. We got independence in 2011. Since then, we have had different instabilities. 2013, we went, and 2016, we went to some kind of civil war. Currently, we are ranked 185 out of the 189 countries on the index of the poverty index by World Bank. We have a relatively young population of 73% of the population is less than 30 years. We continue to have some natural disasters like flooding, which affects almost half of the country, and we continue to have a lot of insecurities in different problem areas in the country. On the map on your right, we are showing the areas in red as the counties and states where we do programming. Next. Thank you. Hello, next. Okay, the internet is slow on my side. I believe you must be having a slide on talking about the violence of health workers. I will be defining violence on health workers as situations where other staff are abused or threatened with a weapon and occasionally assaulted or in the course of their work. Or health workers also get threatened when the communities in these health facilities are situated or are fighting, and the health worker may be coming from a different community and they get threatened and actually vacate workplace. So those kind of insecurity situations that we tend to have. Now, insecurity really have some factors that predipose them. One of them being the gender of the health worker. Most of the situations where our health workers have bad exposures are being of female gender health worker, but also male health workers have also been exposed to violence from the community members also. Usually the perpetrators are basically family members or a spouse of a health worker, a spouse of a female client who has received family planning services without their authority, and occasionally also we have situations also where the environmental factors have also predisposed our staff to violence. I'm talking of issues like poor infrastructure, or where there's no adequate lighting in the facility, and also because of low staffing level, where there's increased population and patients seeking care, and the staff and the community of patients get worked up as the low service that they're receiving. Yeah, so understanding can also predispose to violence. Next slide. In the landscape of violence, WHO estimates that about 73% of work injuries in 2018 were due to health. In other words, in the workplace, 73% of workers that had violence were health workers, and up to 38% suffered physical violence. Yeah, or in our environment, as I've indicated, intercommunal violence that occurs around the facilities expose our staff and the general insecurity in the communities or where the facility is situated also threaten our staff. So many times they run away from the facilities. Next. Okay, there's international or safeguarding health in conflict coalition reported that in 2020, there were about 19 health workers were actually killed in South Sudan. In 2021, 12 actually died. In 2023, about 6 health workers died as a result of various threats. And the threats that our staff are exposed to are real. We have also had situations where health workers have felt that the health work is risky, or some have reconsidered their position as health workers, and some have left work or as health workers because of a feeling of exposure. Next. The types of violence to health workers, or maybe discrimination, or stigmatization. Or the focus of our programming is on reproductive health, family planning, maternal health, and child health. And based on the social norms assessment we did in the first year, it was very clear that family planning is still an activity that is still not heavily acceptable. So our health workers also feel in the community where they work, or that the community feel that they are or they're stigmatized, are seen to be stopping communities from having children. Yeah, and then there have been gender-based violence to the clans that have been provided family planning, for example, and therefore our health workers, particularly female health workers, have been subjected to what one would call gender-based violence, because their spouses come, the spouses of the clans come and look for the female health workers who may have provided family planning, and then they are also exposed to shouting and threats. Next. So my experience in the violence on community health or healthcare workers in South Sudan have been armed threats. By armed threats here, we mean the male spouses coming armed with an automatic weapon and or demanding to know who may have given their female spouses family planning, for example. And the health workers really feel threatened with an armed person who want to know who actually gave the family planning to their spouses. Yeah. Another issue that we feel has also been of great concern to health workers is a parallel court system. It's like a parallel judicial system. We still have traditional courts in our environment, and also the modern civil courts. Or health workers have been, where spouses have complained, health workers have been subjected to fine by the traditional courts. Occasionally, those additional courts have also passed a ruling that the family planning device that a female may have been given to be discontinued. So the health workers find themselves in a situation where the male of family members of the clan and the family members of the lady appear in that facility, with understanding that the family planning device is an implant, should be removed. So the health workers really feel demotivated, because here they have to do what the court may have indicated, and that also puts them into quite a lot of risk and threat. Yes, we have had situations also where particularly private health facilities that we work with have had to close down because an armed individual visited them and indicated that the female spouse was given a family planning, and the owners of the health facilities are really threatened. Yes, thank you. Next. So how have we responded? Yeah, we have always involved the Central Ministry of Health at the national level, and also the devolved Ministry of Health at the state level and at the county level. And the directors of health at the ministries have always helped us by really calling out the various security agents to help solve the situation. We have always used the available policy guidelines, and particularly the FP 2030 commitment letters that we have pasted in all the facilities to indicate that the family planning services that we provide are legal and accepted by the government. We have also engaged community members, community leaders that understand the chiefs to help us cool the spouses that may be feeling that they have been wronged by having their spouses given family planning. Yeah. And we continue to use social behavior change mechanisms and also look for male engagement processes so that the communities could be aware about the reproductive health programs that we are doing. Next. So I'll talk about the mitigation measures that we do, or our program using resilience approaches, or we work with health facilities to develop emergency response planning. And we also work with the communities around the facilities to also develop emergency response planning. And the emergency response planning include not only natural disasters, but also environments where community members may expose our staff to violence. We have also made use of the community health workers here. We call them Boma health workers that we are mentored extensively and given them skills for community engagement. They visit households and they also use any opportunity of community gathering to talk about health programming and how the reproductive health services are benefiting to the communities. We engage the government security apparatuses in communities where we work so that they can be able to help our situation. Next. Talking about the absorptive resilience, we ensure that there's adequate stockpiling of commodities and also male engagement activities I've talked about as an absorptive mechanism. And as adaptive mechanism, we have developed work with our service providers as mentors to be able to quell any threats of violence when they occur. And we also do in counseling and work with our clients to choose some of the managed methods like injectable DMPA so that they can go home with it without being seen to be making these to the facilities. Next. On the transformative resilience, we continue working with the various government apparatus to see that policies are in place to ensure that the self-care policies are in place and that there are more male engagement opportunities in order to reduce the threats that we end up being exposed to. Next. Then, yes. Then the our work with the community health workers, the Boma health workers, we have some preparedness processes, which are indicated as emergency preparedness response plans. We also do response drills with the facility staff and also with the community Boma health workers. And we ensure that the Boma health workers are really well trained. In terms of response, we work with our health service delivery teams to ensure that they provide integrated health programs, not only whenever they do treatment and care, that they also provide reproductive health commodities that are needed. So that task shifting enables to ensure that the health facility and the Boma health workers are ready. In terms of recovery, the Boma health workers assist in communities that may have had bad experience to ensure that we are working effectively. Some of the lessons that we have learned are related to threats do occur regularly. About workers, occasionally don't report them because they sit as their daily activities where we work. Yeah, and we also continue to engage with the local leaders. Next, some of the takeaways that we can say talk about is that close and regular engagement of communities really help solve some of these activities when they occur, and that the self-care endeavors that we are working with health facilities enables community to access like family planning without being exposed. And the last takeaway, I would say that the engagement processes in maternal, newborn, and child health to us is a very important things in order to enable increased antenatal care and also to prepare them and ensure that we have increased deliveries in under-skilled care. Yeah, thank you. I think that is the last slide we have. Thank you for listening.
Yeah, thanks, Dan. I think we got a little behind on that last slide that you were going through. But thanks again for that. I know you were struggling with some internet issues, but I'm glad that those all worked out. So I want to thank our presenters, Dan, Bukhar, Mohammed, Andrea, and Nefra, first of all. But I do want to turn over to some Q&A. We've got about 15 minutes left. I did see one question in the chat. I think the person who asked it unfortunately has already left, but I saw that Mohammed did answer it a bit in the chat. But I think it's an interesting question. It was directed specifically to the Sudan team, but I think it's applicable for all of these. And so I'll maybe just open it up to all of our presenters to talk about. So the question is, what process did you use to make decisions related to when to shift from your planned programming to the adaptations that you mentioned? And so I think you can talk a little bit about the information on and process for how you know that it's a time to shift and pivot your programs. Mohammed, maybe you could answer first since you did put something in the chat, but I'd be curious to hear from Bukhar and Dan on that question as well. Mohammed, are you still there? You're on mute.
Yeah,
Did you
thank
hear
you,
the
Chris.
question? Okay.
Actually, we benefited from all the advanced tool that we provided by we received from the AMSHA senior management team and core team, like the shock log that help us to analyze systematically all the shocks and stressors and how they impact the program interventions. And we also triangulate that with available information from other analysis that we do it, like by the safety and security team. Also, they have situation analysis report. And when we compare and also triangulate with other, that can give us like real picture about what happened and how that can impact long or short term the intervention on ground. Building also the business continuity plan, the guidance that we receive, and we develop the business continuity plan ahead of time before the start of the conflict. Like we anticipated like alternative routes, for example, for supporting the cash transfer. So included in our business continuity plan using the mobile money to facilitate in case like the collapse of the banking system. All of that has helped us. And also in the guidance that we receive from the agreement officer representative, Alana, and from the USAID mission, help us to decide, like consider the location for safety and security of the team and also for the IMCR party on the ground. So that all of that help us to implement the business continuity plan, mitigation measures, and all the to reprogram or to use the available resources in other safe and accessible location in Eastern Sudan. That I think that all about working in a smaller team in country and wider team with amateur technical leads, with the country support team, with the senior management team, and also with the USAID mission in country and with the agreement officer representative. That all help us. Like we're working in larger teams that all contribute to making smooth reprogramming and shift. Thank you.
Thanks, Mohammed. Bukhar or Dan, did you want to jump in on that question about how you determined it was time to pivot, or how you decide what changes to make?
Okay, thank you, Chris. Usually we have our staff at different levels. Like for us in the counties, we have an officer responsible for the county, and we use different mechanisms to get information on the threats beyond just the health facility, and also linking with the local authorities so as to get the magnitude of a possible insecurity status that may be taking place. And there have been at least one situation when insecurity around the health facility occurred, and we had to use our emergency preparedness plan for the facility to ensure safety of the medicines, and also to temporarily or close or stop working the facility, of course, with the government. So that enables us to ensure that our staff survive, and also the other service providers, those facilities will survive. And we continue linking and finding out what's happening on the ground before we can reopen. And the good thing in the process that you always keep the donor informed, or whenever such threats do occur, and we move on. Yeah. It's true there have been some situations where something has happened rather rapidly, and then we really call for the existing government security practices to move in and help us ensure that the staff on the ground are safe. Thank you.
Thanks, Dan. Bukhar?
Thank you, Chris. Yes, indeed, during this crisis, our goal is really to have our activities ongoing. So what should we do so that the project is not really jeopardized? This is our goal. And we have some references. If there is an issue, is it contrary to the restriction 7008 from the AID or funder, or from the government, the policy? So we analyze, and I think which helps us a lot is the communication from the field and up, down, really continuous communication on the issues, on see what can be impacted. Is it the restriction, or is it the policy? Policy meaning restriction with the coup. You know, there's a new authorities came with their new policies, their new restrictions, and so on and so on. So this is what we use. We refer to this restriction, we refer to the government rules, we refer also to our business continuity plan. What have we planned before? If this kind of things happen, because here in Niger, we know that politically it's really unstable. We know it's unstable. If this happens, what have you planned, and how can you adapt? And we use a lot of adaptive management. Really, it's something that you adapt. You can't tell that next week I will do this. When it happened, you refer to see what are the restrictions, what should I respect, and then you decide. And we do a lot of communication, teamwork, and dialogue with the mission, dialogue with the ministry. Thank you, Chris.
Great, thanks all. And another question we've got here is, and I think some of you already started touching on this, but you've talked about the impact that these shocks have had on your work operationally and programmatically and how you responded to those. Can you talk a little bit about how these shocks have affected your staff? What measures have you taken to ensure the physical and psychosocial safety for your staff? That's to whoever wants to jump in first.
Yes, Chris, indeed, we are lucky here to have within our team a security officer who has really I would say, nationwide network. So each time that we go something or we plan an activity, we refer first to him. Say we want to do to go to this supervisor. We want to do this meeting, and he will check within his network and they say yes. I give you the green light. The second thing is we refer to local authorities. These are very good references to refer to them. This is a type of activity because they are informed on here really well exposed to all this insecurity. You know, it's not the best time, it's not the best place, and we adapt. As I told you, for example, for some training, community workers training in some very insecure, we really bring them to other secure, we train them and they get them back. Thank you, Chris.
Thanks, Bukhar. Mohammed or Dan, do you want to talk a little bit about how the impact on your staff and how you've worked on that issue?
Thank you, Chris. I think the impact was massive on the staff, but what helped us is we use all the available resources that first the IMHR lead agency, CARE International, have like the communication tree that helped us at the first days of the eruption of the conflict, just to keep the communication with the team and to provide all the, just to keep communicating and to make sure that everyone is safe and to provide all advices. And also CARE International, the IMHR lead in Sudan, provided like they formed the crisis management team that provide all support in terms of financial, in like operationally, logistically, provide all support needed for the staff when the conflict erupted in the capital city of Sudan, where we have all the staff more, including national and international staff. Second one, that prepare us to at least take steps ahead for South Kordofan that help us also to arrange for the evacuation plan if something happened to the staff there. The support that we receive also through the CARE International, that the online psychosocial support sessions that help many of the team that have been affected mentally by the situation and displacement and all of that. Provision also additional support received by all staff from operational logistic support during the displacement. And also the support we receive from all IMHR team from the senior level, and also the daily support from country support team that have helped us, and also from the USAID mission team, and also from the Alana AOR. All of that have helped us to pass through the critical time and to make sure that all the staff are safe. Luckily, all the staff are safe still, and they are in a good place, and all of them they are now having internet connection and also telecommunication. But at first, lastly, I can say, in fragile setting like Sudan, other places, like the most important thing is to have like ahead of time, like analysis and mitigation measures in case something happens suddenly, you know what to do next step. And that the good thing that we have the safety and security management plan for CARE International, and also the development of the business continuity plan ahead of time have helped us and contribute to the safety of the staff. Thank you.
Thanks, Mohammed. And Dan, I think you lost internet. I don't know if you're back, but we were talking about the question about what measures you've taken to ensure the physical and psychosocial safety for your staff.
Sure. Okay.
Progress.
Oh. Yeah, thank you. We, as indicated much earlier, we take dedicated process to reach each and every staff that we have on the ground, right from the national level where we sit or that person or touch with our staff in the field, or gives them quite a lot of courage. Where we have been able to evacuate them from the field to another facility, or we enable them to continue providing care in whatever facility where we have shifted them. And we ensure that before they go back, we confirm with the different government security teams on the ground before they can go back to their facilities. Many times, especially when it is a community initiated violence, or they are quite worried, and we ensure that they have security, or the security is assured as they go back to the station by continually reaching them out to find out what's happening. We have also created a mechanism that around each facility, we have contacts with the communities. So the community leadership also reassure us or the security of the staff that we have in the health facility. And ensuring also that we continuously reach them, and we maintain monthly meetings with the center so that they are reassured. Thank you.
Great. Thank you, Dan, so much. And thank you, Mohammed and Bukhar, for your responses on that question. I think at this point, we've got to wrap up our Q&A. We can go on to the next slide. I just wanted to inform you all of some upcoming webinars that Momentum Integrated Health Resilience there as an organizer or a presenter. The first of which is coming up 2 weeks from today on strengthening family planning and sexual and reproductive health emergency preparedness and response. I put the link in the chat to register for that webinar. That's one we're working on with our colleagues at USAID's Propel Adapt and FP 2030. It's a series of webinars focusing on family planning and SRH emergency preparedness. In the lead up to the next ICFP that will happen next year. There will be a series of webinars on this. We also will be hosting a webinar in July. The date was just confirmed to be July 23rd on shock, stresses, and health outcomes, the role of promising health resilience strategies in fragile settings. And then in August or September, dates to be determined on supply chain challenges and commodity availability at the last mile, findings from 7 countries. And finally, a webinar that will be conducted in French on the role of the private sector in improving access to family planning and reproductive health care for youth and adolescents in Francophone Africa. There are several ways you can keep updated on these. The best is to join the Momentum mailing list to get the updates directly into your inbox. You can do that from the USAID website, or sorry, from the USAID Momentum website. I can put that in the chat as well in just a second, or you can just follow Momentum on social media, particularly on LinkedIn is a great way to get updates on these events as well as everything else that's happening across the Momentum suite of awards. So I'd like to go to the next slide and just again, thank you all for attending. Thank you to our presenters, to Nefra for kicking us off, Andrea, Mohammed, Bukhar, and Dan for their presentations today, and all of you for the questions and discussion in the chat. So thank you and have a great rest of the day. And we hope to see you at some of our upcoming webinars in the coming months.
Great. Thanks, everybody.
Thank you.
Thanks,
Thank you.
everyone.
Bye-bye.